Hello, and welcome to the Two View, the cutting edge educational show for PAs and nurse practitioners in emergency medicine and urgent care. My name is Mike Sharma. I'm a practicing emergency medicine and urgent care PA in Dallas, Texas, and an adjunct professor of PA studies.
Mike, I am so happy to see you, and I'm just thrilled about our special guest. So I'm going to let you introduce in a moment. I honestly, I am exhausted and it's late for all of us tonight. So we're very lucky to have our special guest. But before we get into that, I want to talk just a little bit briefly, like just real short about the boot camp. We just got back. Mike and I missed each other just by a day. It was a load of fun. And honestly, I would do it again, Mike. I would absolutely do it again. We had some really great people there this camp, and the recording of the camp, we got some brand spanking new recordings, and we're going to release those to you all very soon.
I'm sorry, caller. Who is this on the line? I didn't hear you introduce yourself.
Oh, I'm sorry. Do I really need to say my name?
Yes, it's an audio podcast. They can't see your face.
I'm sorry. I've just been so excited about our special guest who I'm just thrilled that we're building up the suspense here. My name is Martha Robertson. I'm a nurse practitioner in Northern California, and I'm also teaching. I'm doing a lot more teaching these days. So that's me in a nutshell.
I thought I recognized your voice. Well, it's so glad to be back with you again. Yeah, I'm really sorry that I missed you between everything going on. It's kind of a bummer, but like it's great to see you again in this way. And it's also great to see our special guest today. We've brought back the King of Pain. That's what we call him. He's far too humble to call himself that, but that's the name we give him here. Maybe it's called the King of Pain Management is probably what we should call him. Anyways, it's Dr. Sergey Motov. Dr. Sergey Motov is an emergency medicine physician and research director at Maimonides Medical Center, one of my favorite philosophers, Maimonides, out in New York City and Brooklyn. If you read his X bio, he's at Pain Free ED. He says first words, he is an EM algiatrist. Sergey, welcome and tell us what that means.
Hi, Martha. Hi, Mike. It's so great to be back, and I really appreciate you guys having me over. Algiatry, well, it's a pain medicine or science of pain, and I love the sound of it because it just sort of sums up what I've been doing for the past 15 years with my life. And as you pointed out, I've been pushing, exploring, researching ways of providing more safer and more effective pain management to ED patients with variety of acute, and chronic painful conditions.
Yeah, I don't think you wrote the book on pain management, but you at least have edited the book. I have your EMRA pain management guide that you and I think is it David Suzuki is your partner in crime there?
David was the editor-in-chief, and he was very gracious to extend an opportunity to help him to edit the book. Yes, we did together.
Yeah, I have that EMRA pain management guide. That is part of my everyday carry when I work in the emergency department. And so thankful that you guys put that together. We'll put a reference to that on our website. That's going to be 2view.fireside.fm, the number 2view.fireside.fm. We all got together a couple years ago, Martha and I, Sergey, Ken Milne, Rick Bucata, Rick Pescator, and Sergey really led us down a fantastic, like, the ground floor where everyone should be in acute pain in the urgent care and emergency medicine. We'll put a link to that talk and video in our show notes at 2view.fireside.fm because if you don't know that stuff, what we're going to get into today will just really bake your noodle because we're going to go beyond that. Okay. So like I mentioned that day, like I had already listened to Sergey and read his stuff before then. And then I still learn things when I listen to that talk. And I'm so excited about the stuff we're talking about today. We are going to talk about the ugly, the bad, and the good in pain management. And we're going to start out ugly and we're going to end good with all the things that are up and coming. But first, we got to go ugly. Martha, what is our first ugly topic today in pain management?
Oh boy, this is a really scary one. And I think we could spend the whole show talking about it, but we're only going to make it the first part. And that is the ugly truth of the rising deaths with opioids, with co-prescribing either gabapentinoids, benzos, and other muscle relaxants. And just looking at the National Institute on Drug Abuse and other resources like the CDC, almost 20% of overdose deaths, and they could be even higher today. This was a 2021 statistic, involved some kind of co-partner in crime. And it's very scary. And, I think I feel overwhelmed by this sometimes because patients have multiple problems, not just pain, and wanting to prescribe more of these pain medicines or muscle relaxers together. It seems like the right thing to do at first, but it ends up being oh so wrong. Sergey, what do you think about co prescribing these medications and how we can make this a little prettier, a little nicer?
So I'm with you, Martha. It's very concerning, and I'm actually happy we start with the ugly part because I'm always happy to finish on a happier note. And I would just point it out that I believe this co-prescribing it's a result of unintended consequences of very well and very meant good ideas because in light of opioid crisis, EDs across the country has been not forced but has been looking into ways of find alternative to opioids. And my problem with it that we've started repurposing classes of drugs that have very questionable analgesic efficacy and very concerning adverse effect profile, which leads to this very challenging co-prescribing. And you brought up the major three groups of drugs classes that I'm going to briefly talk about: benzodiazepines, gabapentinoids, and so-called skeletal muscle relaxants. I call them deathly hallows, OCD analgesia, or analgesic deathly diet or triad. And statistics, you brought 2021, I have a 2022 data that out of the EDs, opioid and benzodiazepines co-prescribing occurs in about 20% of all discharge prescriptions, followed by gabapentinoids with a 13 and then muscle relaxant of 15. And the reason is important, A, benzodiazepines, gabapentinoids, and muscle relaxant traditionally used for back pain, and data clearly show they're not effective. They're very ineffective when it comes to pain relief and improvement in disability. So if drug is not effective, why are we even adding it? And to make things even worse, co-prescribing of opioids and benzodiazepine leads to tenfold increase in mortality associated with respiratory depression. Co-prescribing of opioids and gabapentinoids leads to threefold increase in dizziness, drowsiness, cognitive impairment, and worsening mortality. In addition to it, gabapentinoids potentiate euphorogenic property of opioids. So you get high in gabapentinoids by itself, you get probably triple high if you combine gabapentinoids and opioids, and then you have this worsening of respiratory depression. And lastly, if you combine opioids and muscle relaxants, specifically carisoprodol, which is abuse prone, you increase chances of dying from overdose by 2 to 3 fold rates in comparison if a patient would get a prescription for just opioids alone. So statistic is staggering. Unfortunately, I'm trying to be Patch Adams, but as of right now, I'm very pessimistic. And I'm just hoping that by following the evidence and understanding what this medication do, they do more harm, they do good, we might be able to reduce their co-prescribing and overall utilization in the EDs.
Now, I just wanted to point something out. It's a specific document that I found published by the CDC that actually addresses this very concern. It's their clinical practice guideline for prescribing opioids for pain. But the reason why I really took a deep dive into looking at it was because they have multiple recommendations. And what's really interesting to me is that we're always looking to layer treatments for pain. We're like, well, Motrin and Tylenol, or just say acetaminophen alone is just not going to be enough for this patient. But we know that there's a lot of robust data that combining acetaminophen with an NSAID can have some really great analgesic effects. But then we're like, oh, what else can we do for this patient? And what I really like about this CDC guideline is that their first recommendation says that non opioid therapies are, they can be very useful. There are so many different things that we can use, and we should maximize the use of non pharmacological and non opioid therapies for patients before we go to that next step. Even like we're thinking way far down the line here. Why not just start with some of these non opioid or non pharmacological interventions before we even get to that point? And that's not to say that we should deprive patients from treating their pain, but why not start in a stepwise approach?
If I may, I love what you said, but I feel like, again, everybody uses this word pendulum. I'm not going to repeat it because it just irritates living wizard out of me. We're moving from one extreme to another. And I think by doing the stepwise approach, and sort of this guideline prescriptive way of managing pain, it defeats the very purpose. And good example of it, we are repurposing non-opioid analgesics, so-called, that have very bad adverse effect profile. Some of them probably even worse than opioids. So what I'm proposing, while I'm big proponent on utilizing non-pharmacological treatment modality from get-go and non-opioid analgesia, but analgesic that have proven records of working rather than using something that have been repurposed outside of the FDA-approved indication or that they need to be. Gabapentinoids, these are anti-seizure medication, let alone they'll be helpful for neuropathic pain according to the FDA approval, but they're not approved to manage acute pain, acute back pain of non-specific or neuropathic pain. And maybe if we do this, right, and then focusing on opioids, we need to find a balance. Again,
Right.
if you find the right balance, right dose, right frequency, right patients, you can customize it. And there is nothing wrong to prescribe an opioid for the patient who will benefit from them, but understanding the potential short-term, long-term risks. And that's how would I approach it.
Yeah, I really like that a lot. In fact, looking at all these guides, actually had reached out to you about a month ago, and I said I was giving a talk on pain management at our boot camp course, and I was wondering if you would be willing to share, your top 3 or 4 gold standards. And, the first thing you said was, well, there isn't one single document that tells us what to do or, says like, we know that this is 100% effective. It's definitely a balancing act. And all these clinical practice guidelines just provide recommendations. They don't replace clinical judgment or the individualized patient centered decision making care. So keep that in mind anytime we reference anything. I think it's valuable to know there's lots of things out there.
Well, it's funny you mentioned reaching out to Sergey for help. Maybe that's a little theme here we have on our podcast. I reached out to Sergey for help a little while ago when I was running into a problem with opioid dosing. Um, I I'm a firm believer of like, let's give somebody like the appropriate dose, doing the Goldilocks dose, not too little, not too big, but the right dose, whatever it may be. And it may be something that people are just not used to. And so what I've started doing based on, Sergey and other people's guidance here is like weight-based opioid dosing. I think in so many ERs, when people order morphine for somebody, they order a morphine. Like they order a vial of morphine, whatever the vial is, whether it's 2 or 4
Yep.
or whatever or 5, they order whatever the vial is in the Pyxis or whatever medicine prescribing system you have because it's just easier for it to be administered. But then what happens is we run into problems because when you give a morphine, it's not based on the person's weight, it's not based on other medicines they're taking, it's not based on things like age or risk of respiratory depression. And so um in this situation though, I was looking for somebody who was like a medium weight person, like a 65, 70 kilo young adult with no big comorbidities that would put them at risk. And so I was like, okay, it's 60 kilos. Let's give 6 milligrams of morphine instead of just a morphine that came a 4 milligram vial. Um, and I got a tremendous amount of pushback, a tremendous amount to the point where I talked to like my ED leadership and I was like, why are we having people pushing back so hard? Because, but in the moment, what happened was this. I got checked on my references. They were trying to check my receipts on this thing. And they were like, well, what is your reference for prescribing zero point 0.1 mgs per kilo? And I was like, well, okay, thankfully my everyday carry includes the EMRA pain management guide, and so I pulled that out and I sent that to them. But it really got me thinking. It's like, okay, well, where is the reference for that? Like, where are we getting all this information? And you shared with me a great paper or by Bijur so long ago. Honestly, I mean, that was what 2005 we were just talking about, right? A
Mhm.
long time ago. Can you share kind of because when people get asked this question out there, why are we giving this much morphine for somebody? I want you guys to have this and gals in your back pocket. And again, to few.fireside.fm, we're going to have this on our thing. Can you talk about this study that suggested what morphine doses, maybe at least safe, but maybe not even effective for controlling acute pain?
Thank you, Mike. This is a really interesting, and it's been some extra passion of mine to kind of find exactly the answer to what you brought up. What would be the right or appropriate dose for an opioid? And I'm probably going to disappoint you right now. There isn't any.
Never, never, Sergey. You never would do that.
No, and okay, but what I've said that there is no right dose
Yeah.
because you need to again, and what Martha said at the last conversation we just had, which it needs to be individualized, and I wholeheartedly agree with you. Patient-specific, pain syndrome targeted approach. You see a person in front of you. You brought a very good example. Uncomplicated 60 65 kilos person, no comorbidity. Yeah, you can do weight-based dosing, which traditionally we describe as a zero 0.1 mg per kilo. The study that Mike just quoted out was published in 2005, which actually stated that zero 0.1 mg per kilo is not enough. It wasn't working for close to 50% of patients, which I am personally, and I'll tell why I kind of disagree with the results.
Hmm.
I recently switched to teach the following. It's almost irrelevant. What is your initial approach to opioid analgesia that would be in the emergency department? Whether or not you choose weight-based dosing or you choose fixed dosing. The most important part is what are you going to do after? And the key to successful opioid therapy is titration. What we do as a physician, we completely neglect this very word. And a good example I've witnessed on numerous occasions when patient gets 4, 6, let's say even 8 milligram of morphine, physician disappears, comes back an hour later and asks, how is your pain? And patient says, well, I'm in pain. The problem with opioids is you need to know your pharmacology. And if it's morphine, you need to reapproach patient at 20 minutes mark and see how they do. If it's hydromorphone, maybe 15. If it's fentanyl, it's 10. And there's additional things we can talk about in the details. My favorite study was actually published in AGEM, I believe, in 2010-11. Our French colleagues did a study when they used 3 milligram of morphine and I believe 2 milligram of morphine every 5 minutes. And what they came up with, the dose that was defined effective was close to 8 milligram. I found it fascinating, but at the same time unfeasible. You guys can support me on it. We have no luxury of having nurse at the bedside with a patient giving pushes of 3 milligram of morphine every 2 to 3
Push dose
minutes.
morphine
Precisely.
every few minutes.
Yeah, what happens? That's why I'm a firm believer we've chosen, because of the intricacies of our culture in the EDs, too many patients, we need to move fast and everything else. We decided to use this large upfront dosing, which in a healthy individual, it's safe. Not so healthy, comorbidities, relative contraindication, it may not be too safe. So what I'm saying is, if you choose weight-based, go for it. If you choose fixed, go for it. The right dose really does not exist. Titration is the key because single dose of opioid, whether or not it's morphine, hydromorphine, fentanyl, would ever, or probably never, if never, would not work to the level that you would expect. That's why I love titratable analgesia, such as opioids and ketamine, and everything that I can have way of titrating and controlling pain at slightly greater extent. So yeah, it's not a really clear-cut answer. I'm sorry, Mike and Marta, for disappointing you, but I cannot give you the right dose. It's a
Well,
patient in front of you.
that's understandable, and I think you bring up some good points. Like I don't think I've, unless somebody was really in extremis or like really in extraordinary pain, I don't think I've ever come back around 20 minutes after morphine was administered to check on someone's pain. So like you gave me a lot to chew on there as far as, not waiting an hour or 2 hours to reassess pain for some of these things.
Right.
But one point I wanted to make before we moved on from this Bajor study is that regardless of whether pain was adequately treated or maybe there was some oligoanalgesia, um, there was there was no adverse safety events, I believe, like no significant ones with this zero 0.1 mgs per kilo dose. Am I on track with that?
Yes, you are. But I have a couple of, practical points to it because if we go to someone who's 100 kgs or even larger,
Oh, sure.
10 milligrams single dose of ibuprofen, it's a large dose. It's a really large dose. Even for ideal body weight, we get to close to 10 milligrams. We need to be very careful how we're going to be doing this. So my personal approach, anything above 8 of morphine, I do not push. I use as a short infusion. Just put some in a normal saline bag and let it rip over 10 to 15 minutes. Trust me, analgesic efficacy remains the same, but potential to cause respiratory depression, a little loopiness, even nausea, it's significantly reduced.
Whoa, whoa,
And
whoa, 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 whoa. Hang on. Can we just repeat that for our listeners? Because
absolutely.
I guarantee you nobody's doing that. And
I'm not
that
doing that.
is
Yeah, that's
phenomenal
I love that.
information. One more time.
Absolutely. One more time. So my personal practice has been that if I ought to choose a morphine, and I believe the dose should be 8 milligram or even 10 milligram, I don't do larger than 10 milligram. I pretty much not do 10. But if I do choose to use 10 milligram of morphine, I do not use intravenous push. I spike the normal saline bag, the little 100 ml, and I infuse this 10 milligram of morphine into the bag and I let it drip as a short infusion over 10 to 15 minutes, with the premise that I'm reducing the initial jolt of histamine release, potential for respiratory compromise, maybe a little less nausea. But I, again, can reassure you that analgesic efficacy remains the same and patient feels much, much better.
That's
Amazing.
amazing. That's
I
amazing.
love it.
Yeah. Well,
Uh,
at the very least, 6 milligrams is, for the most part, you got to treat everyone as an individual, but 6 milligrams for a 60-kilo patient, probably not an unsafe dose if no other comorbidities are there. So I just wanted to float that for people who are used to pushing 4 or 5, and that's it. But I agree, Sergey. You got to take everyone as individuals. But I just want to express that there are studies that back weight-based dosing as one of the safe alternatives. Just be careful. I agree. Like I usually don't even hit 8 or 10, even if they're 80 kilos. I'm like, let's try 6, and then we can always do, another titrate after that.
You
I'm with you
know,
100%.
yeah.
I'm sorry, Martha, go ahead.
Oh no, I didn't mean to interrupt anybody, but I think another solid point again here is that pain is so multidimensional in
Mm.
nature. And injury honestly is just one cause of pain and there's so many factors that play a role in the pathogenesis of pain that we might touch upon this in our next segment about patients who have depression and pain. And there are multiple studies that look at mental and physical pain and the exacerbation of physical pain with mental illness and depression and other factors, this multidimensional whole conundrum of pain and the pain syndrome itself. So, I think people get really stuck on this like, oh, this patient had surgery and now they have, post op pain. And so, like, this is what we've always been doing. But, who knows? Maybe that particular surgery was a life changing event for them, or they almost died, or it wasn't a routine thing. You're dealing with all different types of personalities and patients, and you have to go just one step farther to talk to them and get to know the patient and go back and reassess them. Like Mike, you said, you're not going back in 20 minutes to assess them. Well, maybe now you will, right?
No, yeah. I mean, I don't think I'll wait as long as I usually do. Honestly, that's fantastic.
Yeah.
That's a good point. And Martha, I'm so happy you brought this up. This conundrum, this multifactorial entity, what a pain it is, such a complex presentation that we need to be aware of all the components, biological, physiological, psychological, and so on and so forth. I just wanted to just bring this one thing, and maybe you guys can support me on it. Again, nothing has changed over, I would say, probably close to 15 years. And I'm very unhappy to admit that we as a clinician, we for some reason, and I know the reasons, we are so morphinophobic, but we're so hydromorphinophilic.
Mm-hmm.
And this is exactly capitalizing on what Mike just said. We have issues of giving somebody 6 milligram of morphine who would greatly benefit from it, which is really appropriate dose. But we're so not uncomfortable to give somebody 2 milligram of hydromorphine, which, as we know better than anybody else, equals 16 milligram of morphine. And that's why it gets me absolutely infuriated to the
Mm-hmm.
point up to still point we have not mastered the equi-analgesic conversion with opioids. And we have this double-digit phenomenon. We're so petrified of giving 10 milligram of morphine, but when it comes to single digit of hydromorphine, we tend to forget the actual conversion. We're happy to give 2 milligram of hydromorphine, 3, even 4 milligram of hydromorphine, a single intravenous push dose. It's 32 milligram of morphine. That's insane. And
Yeah.
we're very comfortable. But we're not comfortable with 6 milligram of morphine. Go figure.
I was telling you we have a whole second podcast that we could do, like all these other topics we were thinking of on top of the topics we have today. Like there's so many things, but like that's another topic that is so. See, I personally am the other way because I feel like I can dose morphine, like I can do 5, 6, 7, 8 instead of hydromorphone. I'm like 1.3. Like it sounds so awkward. And the nurses are like, what am I doing here with like
Yeah.
1.3 versus 1 point, 6 or whatever else. But that's just me. We're not really talking about pediatric pain management specifically today, but Martha, we do have a Mastering Pediatric Emergencies course coming up here in heck, just 2 short months. Is that correct?
Yeah, so short commercial break here. Basically, honestly, our courses, when we put on these short little shows in Las Vegas, we really have a great time. And it's been a year since we've done the pediatric course. This is our second time. Last year was our first run of it. And the dates for this are September the 10th through the 12th. I'm just yep, the 10th through the 12th. Now that's the middle of the week. That's a Tuesday through a Thursday. So maybe, you're a weekend person that weekend and you have a couple of days off. Even if you just came for one of the days, I guarantee you'd have a great time. And then you would be able to have the self study course. Um, One of the things I like most about this pediatric course is that we do talk a lot about pain management. We don't just talk about pain management for kids, we actually talk a little bit about pain management in the very beginning of parenthood for the mother post delivery. And I
Wow.
think it's very important, although rare. We might be delivering a baby, OBGYN might be there, but you might be working in a rural shop and you got to think to yourself, okay, I'm taking care of baby, I'm taking care of baby, but what about mom? So we cover a little bit of that. And we also talk about treating kids' pain and how not to be afraid of it and what is safe and what are some recommendations that these experts give us, like how and where do they get their information from and why do they feel that it is effective? It's not just one person's opinion on stage, it's a collective group of pediatric specialists getting together and discussing this. So please check out our website with course details, www.ccme.org, and see what we have to offer. I would love to get some new people at that course. Even if you're terrified of kids, well, if you are, this is the best course for you.
Well, all the more reason to come. And, these aren't just sages on stages. These are people who have been there, done that, have treated innumerable amounts of children and seen all the ways kids can present and seen all the different wrinkles in taking care of kids. And so, like, if you aspire to that, these are people who want to pass the torch on to you. Speaking of passing the torch, we have for just one time this year, it's coming up in December, the original, often imitated, never duplicated emergency medicine boot camp, the main course. It's going to be December 4th through 7th. That's the main course. We have some pre course workshops. So if you want to get facile with the ultrasound probe, that's going to be December 2nd and 3rd. Martha, correct me if I'm wrong. It's not a 2 day course, correct? There are two 1 day courses, or am I totally off on that?
Are you're talking about the specific
The
pre-camp stuff?
ultrasound, the pre-course
Yes.
ultrasound workup. Is it
Yeah.
two 1 day courses?
So yes, it's 2 one-day courses, and that's all you need to know.
There
But
you
you
go.
can
Yeah. So come for either one of those days. And then there's also the procedures workshop, which is December 3rd. Lots of procedures you can kind of try your hand on before doing it on the real thing. And then also a pharmacology workshop by our man, nurse practitioner Michael Gooch. He really dives into pharmacology. A lot of our listeners need specific pharmacology CE. And so that's a great way to get EM specific pharmacology. He's done this course so many times. He is a master at it. And so I think you'll learn a ton, just like I'm learning a ton from Sergey today. So 4th
yeah.
through 7th for the main course, 2nd and 3rd for our pre-course days. Come check it out. It's www.ccme.org. Signups for, I think, both courses are available right now on the website, www.ccme.org.
All right.
We Yeah, go ahead. You have
So
some more stuff to talk about now with Sergey.
yeah, so I want to roll into our segment 3 here. In regards to the advances in analgesia, including regional analgesia, virtual reality, cryoneurolysis, nebulized ketamine. I mean, we have been dissociating people with ketamine since 1971 very effectively in the ER, and it is becoming more and more popular for the treatment of pain. Even more so, I would like to talk a little bit about nerve blocks and personally how I've used them. And then, Sergey, if you could talk a little bit about them yourself and your experience and recommendations. I have found that patients who get a needle of any kind, often have a placebo effect. They know that if they're getting a needle, that this must be the good stuff, right? Like Rick says, just if a patient, they have that migraine or, they come in, they're expecting that IV bag. Don't battle them with it. Just hang the bag. The literature doesn't necessarily support giving IV fluids to someone, but there is something about that placebo effect occasionally with needles. But regardless of the placebo effect, whether that's an added bonus for us, what I really love is that they're actually effective. They do a very good job at stopping pain. And I really want our audience to get good at these. I want them to practice them. I want them to use them in their practice. And I want them to know that when they do it correctly, it will be effective. So, Sergey, tell us a little bit more about what you think on this topic.
So I am, thank you, Mark. I wholeheartedly agree with you. And the way I usually say is that nerve blocks, or special ultrasound-guided regional analgesia and anesthesia in the ED, has revolutionized our approach to, let's say, particularly musculoskeletal pain, right? Vast majority of extremity trauma is amenable to nerve block. And we got so much better as a specialty. And we've gotten so astute as we move from the bulky machines now, we can have this very beautiful hand-size portable devices that can easily be attached to your phone, and we can do amazing things. We really can do amazing things. And what I like specifically to mention for our listeners is that over the past time, almost probably decade, all the past 5 years, we've expanded and broadened our horizon when it comes to a pathology or painful syndrome to that extent that we can use ultrasound nerve blocks. For instance, right? Who would ever imagine 10, 15 years ago that we use nerve blocks for headache? And there's a great deal of literature supporting use that patient comes in with even migraine. You can use occipital nerve block. You can use landmark, but you should use ultrasound-guided nerve block. And it helps. Migraine, occipital neuralgia, there's data that it really does work. Not so rare occasion, but occasionally patients comes in with acute herpetic neuralgia within distribution of cervicocranial distribution. Cervical plexus block, you can block those nerves and you get instantaneous relief, and patients will be forever thankful to you. Again, who would ever imagine that we can manage abdominal pathology to the point of something from outside is something from even inside by using nerve block? Transversus abdominis plane block has been very beneficial in patients presenting with abdominal wall wound, abscesses, hematomas. In recent data clearly showed that you can use nerve-guided, ultrasound-guided nerve blocks for managing pain related to acute appendicitis and even acute pancreatitis. How cool is this? And lastly, we have this erector spina block that can be used for acute pancreatitis and even with patients with lower back pain. Now we can block them and provide good pain relief that can last up to 6 to 8 hours. So I'm very happy, and I think the future is bright. And I just want to repeat what you just said. Our listeners, try to get better. There are numerous amazing courses, and Mike just pointed out, just please look at the website. December's coming up. Sign up, get better, because that's what we do as ideal geriatrists. This isn't within our scope of practice to be better with a needle and with a screen. And there's no way and there's a reason not to do it.
100% agree. And you don't have to take our course. Take any course, really. Doesn't matter to us.
Fine,
Just take
take any
any
course.
course. Yeah.
Chip Lang is like screaming at his computer right now, take my course. So
Yeah.
that's practicalpocus.com for Chip Lang's course, our friend of the podcast, Chip Lang. So yeah, as I'm hearing this, I'm like, I really need to go to one of these ultrasound courses. I'm not facile with the ultrasound transducer, but I mean, just hearing about how I can be treating, it sounds silly, right? Like I can be treating low back pain with something, relatively innocuous, as far as a nerve block. That's just amazing, and we're going to get around some of these things we talked about in the first part of the podcast. We're like, well, let me give you some tizanidine with maybe some opioids and I don't know, like maybe some benzos. So yeah, just if I can do one medication, that's so much cleaner. I feel like than all these multiple medications that can interact with each other. Well, speaking of screens, right? So virtual reality, I mean, is great for, as anyone who has kids knows, the best anesthesia is, I call it Cocomidazolam. You get some Versed and you get Cocomelon, and like you can do whatever you want to that kid, honestly. Okay, but just Cocomelon by itself, any sort of like screens are very good for kids. They ain't so bad for adults either, Sergey. You were bringing up some studies that suggest virtual reality, beyond just looking at a flat screen for pain management. So, like, what are they doing or experiencing in this virtual reality modality? I guess.
Well, you're right. I'm happy to admit it is a present, and I think it's a future. We should probably capitalize on it at much greater extent. Data is becoming more and more robust, not only outside of ED, which is what data comes from, but in within the ED. And I'm happy to report several studies, relatively recent studies, are clearly stating that on adult ED patients presenting with a variety of acute painful conditions, utilization or applicability of virtual reality reduces pain, reduces anxiety, but more important to me, reduces anger. Imagine you got angry patients in pain in the waiting room, you slap those goggles on them and let them to be fully immersed in a virtual world of their choosing, because again, you need to customize it to a patient that you have in front of you. I'm not asking specifically get a great deal of variations to it, but pediatric patient will get something, adult patient gets something else. But it has to be fully immersed, fully immersive, because distraction technique works wonders. And adult patients apparently amenable to be distracted as well. And we all know for the fact that we have a very primitive brain. Why? Because we can only discern one stimulus at a time. So if a visual stimulus or distractive stimulus is much more potent than pain kind of goes away. It doesn't disappear. It just gets parked on the back of the brain, and brain just enjoying this beautiful virtual world. And that's the mechanism how virtual reality works. So ideally, yes, combine virtual reality with any type of analgesia for peri-procedural pain or for just any pain that you believe patient will be amenable to it, and see what happens.
I usually have folks turn on like Taylor Swift or whatever just to listen to some music, but this is like next level having
Yeah.
both, visual and audio. So this is like one step better than Tay Tay, I would say.
I'm so happy you brought you brought up the music. There's a data again coming out of acute pain management, including EDs. And I usually joke, I'll tell you in a second, that music therapy, whether it's a musical diversion, therapeutic listening, actually alleviates pain and again stress and anxiety in pediatric and adult patients. Limited amount of studies, but studies are there. I'm always I've wondered several times. Imagine it's Monday afternoon, 1 p.m., and you decided to blast the music across the entire EDs. And it probably would have worked, but my concern always our colleagues, we're going to start fighting with each
Yeah.
other because someone's Taylor Swift, someone's AC/DC, someone's Metallica, someone's
Right.
Bach or Chopin or Mozart. We just need to find a gold medium. But you're right, music works. Anything can distract patient from pain for virtual full in the brain would probably work. But I would bet on virtual reality as a present and future.
A nice middle ground, I think, would be you too. I mean, I think they're well loved and
Yeah, I'm with
versatile,
you on this.
you know.
Yeah.
But it's interesting that you said that because there are those specific guidelines for the management of acute pain in emergency situations that was published by the European Society for Emergency Medicine. It's about that 90-page document. I read the whole thing. We talked about it at boot camp. And it's very interesting. And they have some interesting supportive literature on music therapy. And it's worth reading. It's worth looking at some of these studies. But moving forward, talking a little bit about ketamine here. So, if you're on the ketamine train, you probably know quite a bit about it already. But if you haven't quite gotten on at a stop yet, I want you to reinvestigate. I want you to figure out why you're not incorporating this into your practice. If you're not, we're going to give you some tips for that. I'm actually reviewing some information right now as we speak. A lot of these articles are published directly by Sergey. So we have a very nice, robust catalog of information. But can you tell us a little bit here about your thoughts on nebulized ketamine?
I'd love to. And I agree with Mark again. So if you haven't tried ketamine, please join, hop on the train, and we'll be happy to take you on the journey. It's been wonderful. Past 15 years really changed practice of numerous city physicians in departments by adding ketamine as non-opioid analgesia. I'm very careful, not entirely as alternative, but at least as a non-opioid analgesic modality that can be used in lieu of opioid analgesia in a subset carefully chosen patients. And we know data is overwhelmingly supportive for using intravenous route, we're using sub-dissociative dose ketamine, which can be given intranasally as well. The paucity of data supporting oral use, but it's not widely used yet, and that's unfortunately oral ketamine not commercially available in the United States. But I'm personally been infatuated with non-invasive route of delivery ketamine, such as nebulized ketamine. And in particular, my group, we've been researching this over the past 5 years. We published several studies on use of nebulized ketamine. We were able to find we believed, optimum dose that provide good analgesic efficacy with the least amount of adverse effect, primarily related to feeling unreality, which equates to being mildly dissociated, and rates of dizziness as well. Recently, we completed a trial where we compared intravenous ketamine to nebulized ketamine. And what we were able to demonstrate that there were no difference for the short-term pain relief. We're talking about 36 to 90, 120 minutes between IV ketamine and nebulized ketamine. And I want to be very clear and transparent. It's a beautiful modality that can be used as a bridge. It's not definitive treatment, although some patient may benefit definitely. When you have a patient with not readily available access, intravenous access, or IV access is difficult to obtain, instead of waiting and torturing the patient with multiple pokes, just utilize nebulized ketamine. Practical point, use breath actuated nebulizer, known as BEN. And reason being, if you slap regular nebulizer on the patient, fair amount of ketamine will evaporate in ambient air. You can see the mist. And there is a potential for occupational hazard and exposure. You don't want to get humid. Yeah, jokes aside, seriously, you have seen
The
how beautiful
contact high from trying to get your patient in the K-hole.
Yikes.
Yeah, so you high, respiratory therapy is high, patient's high. It's just wonderful. It's a ketamine party indeed. But jokes aside, reason I'm bringing up the breath actuated nebulizer, its enclosed canister has a dual mode of action. By flip of a switch, you can either have a blow-by, aka continuous delivery of the medication. But my favorite is breath actuated. Hence, I call this patient controlled nebulized analgesia. Patient takes a breath, medication gets released. You empower your patient to take charge of their pain. Nothing works better than give control to a patient to be in charge of their pain. Trust me, I've done it for the past 7 years, and it really does wonders. Overdose is virtually prevented because should they become loopy, they just stop triggering the breath and medication would not get released, right? And by virtue of having enclosed canister, limited amount of practically nothing gets released in ambient air. Everybody is situated and everybody wins. Furthermore, we can use this very nifty device for the multi-dose. We can titrate nebulized ketamine. If a single dose doesn't work, we'll give a second, even third. I haven't gotten to third dose ever, but I've done on several occasions, I've done up to 2 doses. And if fails, you can add something else to it. But again, there's the data. Take a look at the data, and everything works. Ketamine does work, but I'm just very happy that I have this ability to talk to you guys about the role of nebulized inhaled ketamine via breath actuated nebulizer for patients presenting to DD with variety acute painful syndrome.
I'm not
Awesome.
familiar. Like I'm not. I don't have a respiratory background. Is the breath actuated nebulizer? Do you know? Is that a commonly available nebulizer in most American EDs, or is that kind of like a thing that your ED would have to kind of order and stuff like that? I'm just not familiar.
It's widely available,
Oh,
and we're just not every ED is stuck in it. But if you ever look
oh,
around, there shouldn't be any issue to procure this particular nifty device. And if I'm just gonna get my opinion personally, I think any inhaled drug should be used via breath actuated nebulizer.
okay, very good. Well, I'm used to freezing warts for good effect, but you're talking now the next topic about freezing nerves for good effect. And this is fascinating to me. Like I've had certain times where I've had an injury where I've had kind of like a neuropraxia where like I had some numbness and some tingling and it lasted for a good long while. It's neat to think about the idea of using that for good and not evil, this idea of some sort of a reversible nerve injury. Can you talk about this cryoneurolysis? It sounds like the science fiction future to me.
Right, that's what I felt a few years back when I came across to it, and I vividly remember somehow email exchange me in Marta. It's almost like brain blown because I'm
Mhm.
wow, well that's interesting. The idea
Mhm.
is wonderful, and I have to give a credit, always due to our amazing colleagues, and I'm a big proponent of learning from our colleagues. We're talking about anesthesia. These are the people who actually published fair amount of literature on using cryoneurolysis. Cryo cold neurolysis, freezing the nerve, as Mike pointed out so astutely. And in simple words is you push a highly pressurized, cooled nitrous oxide to -20 to -100 through the specifically designed device that goes from the high pressure to low pressure. And by gradient of the pressure, you create this ice ball that wraps up the nerve. From outside, it does not destroy the endoneurium and perineurium. And then what happens is our axons are regenerated with about 1 to 2 millimeter a day, and the pain really remains for as long as the axon fully regenerate. And we're talking about months and months and months. And here's the reason I'm bringing this up. It doesn't work for everybody. You cannot use this for major motor nerves. If you have somebody on a blocked femoral nerve, patient will not walk for 2-3 months. We need to be very careful which nerve we choose. And usually we use sensory or motor nerve after amputation, or sensory nerve in a pathology such as rib fractures. You guys, almost certain you will support me on this. We're good at controlling rib fracture pain in the ED as a quick fix. But I've seen numerous patients who go home and develop this intercostal neuralgia, and it's painful, it's traumatic, and it turns into this chronic debilitating condition. Well, here you have a chance to freeze the nerve, intercostal nerve, because it has no bearing, it provides sensation, but there's no motor function. And you buy yourself good between 2 to 4 months, some data sort up to 6 months of pain relief without any adverse effect. How cool is this? And just to capitalize on it, there is a paucity of data coming out of the emergency department that this bulky original device that has multiple consoles now turned to be a portable device that you can use with one hand operator. But again, patient with rib fractures, patient with burns, these are the patients, should they fail any conventional therapies, or you believe and you really care about their long-term prognosis, this is probably way of doing it. It's not widely popular. I'm still exploring myself in my shop. We don't have it yet. I know for the fact, I believe 1 or 2 physicians in the West Coast, I believe somewhere in California, they're doing study. I need to find who those physicians are. But I cited some of the literature, Dr. Finrod and colleague, he published the most. It's a fascinating thing to me, because now we're pushing from immediate, quick fix to the long-term fix. And I think this is what, in the long run, maybe another 2, 3, 4 years, we're going to guys get together. We're going to talk about this, what we can do on the long term, because we're good at quick fixes, but we need to make sure the patient can actually feel better weeks and months, maybe afterwards. And that's what cryoneurolysis comes into the play.
We've got East Coast with Sergey. I'm the third coast down in Texas. Martha, this is your coast. This is California. You got to find these guys and figure out what's going on.
I know. I'm sitting here just in awe listening to it, because this is a very new topic for me. And it seems like, wow, there's just another example of something that makes sense that we should try. And if we used correctly in the right patient, can really make some major differences. And I really love that you're able to talk to us about that. Our final subject here, that I feel like I'm saving the best for last, because I think opioid induced euphoria is a hot topic still. I do have some additional questions about opioid induced euphoria, but Sergey, I would like you first to discuss a little bit about these super excited feelings patients get when they have certain opioids, and kind of how that affects us and how we make decisions to choose those medications.
With pleasure. This has been probably one of the biggest passions over the past decade. And the reason being, opioid crisis, we've got so blindsided by virtue of something being forced upon us, and we were all told that the only way to curb opioid epidemic is to focus on quantitative approach to opioid prescribing. What I mean by quantitative: reduce, replace, abolish, substitute. Okay, given. I agree. Nobody should be given 30 tablets of oxycodone acetaminophen combinations, such as Percocet, with 3 refills out of ED for somebody who has a splinter in their pinky. Yeah, given. But somehow, in the midst of this pursuit for this overzealous quantitative approach to prescribing, we forgot the basics. Come back to pharmacology. Opioids as a class, they're very euphorogenic. And for subset of patients, and this is a very important message, not every patient, and based on available literature, vast majority, almost all patients who received opioids, which we're going to talk about in a second, would not get a jolt of high, that opioid-induced euphoria. But there's a subset of patients, roughly maybe 1%, maybe 2%, that's what the data supports. Those patients who were discharged home with, let's say, prescription for oxycodone, acetaminophen, go on persistent use after 6 months. And those subset of patients can experience this, and that opioid-induced euphoria, a jolt of high, of blissfulness, of taking in desire, this insatiable desire to consume this medication because they made them so good, feeling so good. That's what sets them up on the path of self-destruction. And I believe we need to be astute to the fact that in addition to quantity of opioid prescribing, we need to find the balance between analgesic efficacy and an opioid that we consider to prescribe and see whether or not their euphorogenic potential can potentially be harmful. And I'll make it very easy that I've been doing this for the past 7 years. If I factor euphoria and analgesia, morphine given parenterally, and morphine sulfate, immediate release tablets given orally, are go-1 opioids of choice. Only, again, I'm balancing ability of these opioids induce euphoria, which in subset of patient can lead to harm and misuse, abuse, diversion, overdose, and death, and analgesic efficacy. Data clearly stating that morphine sulfate immediate release less euphorogenic in comparison to oxycodone and hydrocodone. Less euphoria leads to less misuse and abuse because street value of this medication is significantly cheaper, and diversion is essentially prevented.
Yeah.
So for that very reason, I just want to make sure that we understand when we use opioid, look into the qualitative approach of prescribing by focusing on opioid-induced euphoria.
That's honestly great way to sum all this up in regards to the euphoria. I just wanted to ask you, um, my students frequently say, hey, I don't want to prescribe oxycodone. I'm going to give hydrocodone because, I want less euphoric effects for this patient. But then I have other students that say, like, how do I make the decision to prescribe the hydrocodone versus the oxycodone? Um, I have my own opinions on this, and certainly some of it is based on research, but some of it is also just based on the patient's preference and what their diagnosis is. But how do you suggest choosing between oral hydrocodone and oral oxycodone for the treatment of pain?
Wonderful question. I've encountered myself several times, but I'm just going to reiterate what I mentioned to you earlier. If you decided to prescribe an opioid, it shouldn't be oxycodone and it shouldn't be hydrocodone. It should be morphine sulfate immediate release. Available in tablet, available in oral form, and frankly, available in rectal form, but it's very extreme usually for patients with a dysphagia or oropharyngeal cancer, and list goes on and on and on. Again, reason I'm bringing this up, Dr. Whiteman and colleagues, our colleague from emergency department, did a systematic review specifically looking on likability and abuse liability of commonly used opioids. And what they found that morphine sulfate immediate release was slightly better than hydrocodone, but was definitely better. Both morphine sulfate immediate release and hydrocodone were less euphorogenic with indices, less potential for misuse and abuse based on likability and abuse liability than oxycodone. And I've done great deal of research myself. I do believe that oxycodone should not be used as a first, second, even third line of analgesic of choice. If morphine sulfate immediate release fails, consider hydrocodone.
Mm. I think it's going to be hard for
It's
people.
going to be very hard. I'm with you 100%.
And it's still hard for me. And I just wanted to have you say it again. I know that the answer is what you said, but I don't know how we're going to make that a thing more, because patients, even the expectation is morphine. I can't believe you're giving me the cancer treatment drug. This must be serious. The stigma around morphine is extensive. So I don't know what the solution is to that.
I'm with you 100%. And again, I just want to reiterate very, very important point. We're very good at what we do right now when it comes to prescription, right? We focus in vast majority of us prescribing 3 days worth of opioids, tops 5, and we use a minimum effective dose. And some may say, well, 3 days of oxycodone is not going to mess anybody up. You know what? It's probably truth in about 98 to 97% of the chances. I know my colleague across the street, Dr. Irizarry and Dr. Friedman did a study, And they demonstrated that prescribing oxycodone to opioid-naive patients out of the ED for 3 to 4 days rarely favor results in persistent misuse. They followed them for 6 months. Now the question is, maybe 6 months is not enough. Who knows what happens a year or two after? But again, what if there's a subset of patient? Then the question, let me become a little philosophical, is a one life is worth not to prescribe. One life lost is worth enough not to prescribe the very medication. I'm with you 100%. It's very, very difficult to change people's mind, but by leading by example, by citing literature, and by slowly winning them over, by just explaining why is it important to focus on opioid-induced euphoria and choose the one that may not screw somebody up on a short or long term, it's important. It is important.
Yes, and I really appreciate what you said. I think some may argue, and I've read a little bit about this debate about the morphine versus the oxycodone and the hydrocodone, this euphoria thing that we've been talking about, is that we started off this podcast talking about the multidimensional aspects of pain. And for a lot of people, that escape, that euphoria, for them, that's why they choose, like they get to choose between oxycodone or hydrocodone. If it's their choice, they're going to choose the more euphoric drug. And we know as clinicians that this does put them at greater risk for all kinds of misuse and abuse. Certainly. I mean, I've had both drugs, for the treatment after surgeries, and the euphoria is definitely different, 100% different. But again, prescribing the morphine is going to be a difficult and challenging role for us as clinicians moving forward. Um, in small rural communities and teaching the public, I still find there are going to be barriers. But hopefully, podcasts like this, your research, your colleagues' research, can put us on the right path and help us get to better treatment of pain.
I certainly hope so. Beautiful summary. Thank you, Martin.
I just want to say my splinter really hurt, and that oxycodone made me feel a lot better about myself when they prescribed it to me. Okay, I only used it when I had to. I promise. Okay. Well, now we're going to look away from opioids, right, and try to find other medications that don't involve opioids. But the problem there is, like, sometimes are we trading one problem for an equally bad problem? We're not really improving it. It's like, oh, well, like we kind of mentioned earlier, like, I won't give morphine, I'll give gabapentin. I won't give morphine, I'll give, you know, uh, carisoprodol or something like that. And I'm just kind of like,
Or
I'm just
tramadol.
swapping. Yeah, I'm just swapping problems here. And so, Sergey, you would kind of for audio listeners, Sergey about shook his glasses off his head just now when Martha said the T word. We won't even say it again. It's like he who shall not be named in Harry Potter, right? Like, don't say
Precisely.
it, otherwise Voldemort comes around.
Right.
We had enough Deathly Hallows already. No, let's not do the
Yeah.
master of all masters. No, no T word, please.
Exactly. There we go. Well, so can you talk about the problems you're seeing there with medications that are, maybe this is a great place to use the T word. Sadly, we're trying to find these other medications as opioid alternatives, but we're just causing different problems in our patients. What's being seen out there in that realm?
So, Mike, the thing is, you're right, but maybe we need to just hold the horses and maybe we need to just pause a little bit and ask ourselves, why are we looking for alternatives? We have several classes of analgesics that have proven decades of efficacy and relative safety when you dose in the proper regimens for the proper duration of time, right? We talk about NSAIDs as a class. We do talk about local anesthetics. And we talk about regional anesthesia, of course, already. Now we brought up ketamine. On case-by-case basis, we can probably reduce ourselves to use lidocaine, which is not entirely safe medication. But these are the analgesics and anesthetics. And then again, maybe we just ask ourselves, and we started in the beginning with the repurposing of the drug with the question of analgesic efficacy, and again, skeletal muscle relaxants, gabapentinoids, benzodiazepines. Yes, anecdotal evidence, and somebody who's been practicing immersive medicine for so many years, yeah, have a torticollis, benzos work. Of course they do, right? But the fact is, I think we just need to pause, because my concern is only by that blind pursuit of finding alternatives will set us on a path of destruction, of making more harm, or causing more harm than causing good. And I'm going to go back to an opioid. We know how do they work. We know the classes, we know the dosages, we know the duration. We're really good at opioid analgesia. What screwed us up in the first place 20 years ago, that opioids were given interchangeably without any consideration to people who should not be getting them in the first place, right? And that's what
Mm.
everything started. But as long as you know, I usually, I'm going to put this in a very small context to sum this up. As a deep physician, it is my duty to know three things. I get to know my patient with respect to what do they have. I need to know the drug and the comorbidities, and I need to know the drug-drug interactions. If I honor these three things, I'll be very, very successful with 3 or 4 classes of analgesic that I'm using. But if you're really going to push for non-opioid analgesia, antiemetic, dopaminergic, there's a beautiful class of medication. In the ED are fantastic. And you know what? To make things even harder, I'm almost convinced that there is not a single entity when it comes to pain diagnosis or painful syndrome that we cannot manage in the ED for the first 5, 10, 15, even up to 1 hour or 2 hours. The art when it comes to algaiatry or pain medicine, science of pain, is what we're going to send this patient home with.
Mm.
This is what conundrum comes into the place. And that's why we need to use our brilliance, our knowledge, our understanding of those drug interactions, what works, what doesn't, and we need to be smart about this. But unless we're honoring patients in front of us with all the luggage, whatever drugs we're giving, and drug interactions, we are going to fail. And again, I just want to warn our listeners, not warn, just caution them. Pursue non-opiate analgesia with a clear set of mind, and just always ask yourself, is what I'm about to give to the patient, is it safe? Is, most important, is it effective? And don't be afraid to look up the literature. Look at the evidence. And evidence is good. Evidence is growing on any given day. And there's a great deal of data. Some of the stuff that we are using interchangeably should not be used at all.
I was just doing a class today on back pain and the urgent care for an organization I'm with, and I dropped your name, Sergey. I said look, anything with the Motov name on it is legit. Okay, whether it's the EMRA pain management guide or any studies you see, if you see Motov on it, that is kind of like the stamp of approval that you need here to know that what's in that document is good. And
Yeah,
like Martha, when you told me we're gonna have Sergey on today, I was just so excited. And Sergey, you blew us away. Like you exceeded
truly,
expectations as you
truly.
always do. It was a real joy to have you on
And
today.
the other thing is, honestly, we all love what we do, or else the three of us wouldn't be here tonight. But I really hope that this particular podcast inspires one of these listeners to do something more with what they're currently doing. And that is what I've learned most from you, is that you chose something that you were passionate about and you are good at, and you really excelled at it. You publish it, you teach it, and you live it, and you do it. And you do it in such a poised, modest, and effective way that we all need mentors, and we all need leaders in this field. And I really, really appreciate your time and the guidance that you have given us today, not just about pain medicine, but how to explore a topic in depth, in detail, and effectively.
You are guys amazingly kind. Thank you so much for your phenomenal words. And in my turn, look, I'm enjoying sharing the platform with you as the three musketeers who are on a quest to do good by our patient when it comes to proper, effective, and efficient pain relief. I'm honored to share the stage with you today, and thank you so much for giving me an opportunity to share my observations, some of the work that I've done in the past, with the whole purpose to get people out of the comfort zone and follow the passion, follow the thing to do things better. So thank you. Thank you so much for having me.
Thank you.
It may be the longest show notes we've ever had on the podcast. They're going to be the
Oh,
best dang show notes. They could fill a textbook. It's going
yeah.
to be at twoview.fireside.fm. We probably went through probably 30 different,
Papers and yeah.
studies, papers, whatever else here. They're all going to be waiting for you at twoview.fireside.fm. Thanks to Sergey and him bringing the knowledge here. That's been our podcast. More information on the original Emergency Medicine Boot Camp, the Mastering Pediatric Emergencies Boot Camp, the Emergency Medicine and Acute Care course. There's still one left this year, Key West. It sounds pretty hot to me, hot like cool. Any of our courses are available either live or streaming at the Center for Medical Education website. That's www.ccme.org, www.ccme.org. If you want to reach out to us or to Sergey through us, then please feel free to write us at our email address. That's 2viewcast@gmail.com, the number 2viewcast@gmail.com. Please send us any sort of feedback, but maybe also, no pun intended, pain points that you have in trying to carry out some of these suggestions that Sergey has brought to us today, because we all face different struggles in our EDs. On, my joke is that everybody wants to be evidence based until it's time to do evidence based things.
Mm.
Like when it's really, that's when it meets the road here. The rubber meets the road. And so you have to, like, how are you going to carry out this evidence based approach against institutional inertia, against peer pressure, against educational hoops, stuff like that. So write us 2viewcast@gmail.com.
Well, that's it. Thanks for listening to this episode of The Two View. If there's some new course that you want to check out, please, if the dates don't work for you, we're working on 2025. So keep checking back for more and definitely come join us.
Thanks for listening to this episode of The Two View. You can subscribe and rate us on Apple iTunes Podcasts, Spotify, and YouTube Music. Search for Two View Emergency. That's the number 2View Emergency. It'll come right up. Ratings help us climb the charts so that other clinicians get some Two View goodness. And now, if you like YouTube and you want to see the video blog instead, you want to see Sergey's fetching glasses, you want to see Martha's drum set in the background, then you can catch us at ccmelive.org or search for Center for Medical Education on YouTube. Don't forget our website where you can go next level on the dozens of topics we went over today. Again, that's 2view.fireside.fm. Our audio and video engineers are Ricky Bucata and Dave Pett. Show notes, good luck, are by Meg Dipple. You got a heavy load this time, Meg. Sorry about that one.
Thank you again for tuning in, friends in EM. Share this podcast with a friend. Share your thoughts via email. And thanks for sharing your time with us today at The Two View. Have a good day and a great shift.